just explain it like I'm 5.
Welcome back to the EX5 podcast, Explain It Like I'm 5 in long form. Today, we've got a very special guest, Dr. Damon Heybrock.
Good to be here.
I wanted to have Damon on because he's a pretty level-headed guy, and I wanted to have a good conversation about healthcare, health insurance in the United States. And I couldn't think of somebody better than a doctor who sees it from every angle. Him as a doctor, patients, and then as well as the back end and the insurance companies. And the point of this conversation is not to have a political debate. So if you're thinking this is going to get into politics, it's not. It's really to walk us through, explain it like I'm 5 healthcare. So with that in mind, Damon, thank you for coming on the show.
Thank you for having me. I appreciate the invite. I appreciate the thoughtfulness of having a doctor involved in a healthcare conversation.
Yeah, because everybody thinks that they're an expert in healthcare. None of us are.
Yeah.
It's one of those that moves right to the top of the conversation. Let's talk a little bit about your background.
Yeah.
You as a doctor, what makes you a little bit different, probably why I called you here.
Yeah, absolutely. So I'm a family physician. General practice means I take care of people from birth to death, hopefully avoiding the second. But I did residency here in town. After residency, I was at Cerner as their on-site physician for 10 years. And that was a whole different care model geared around having access, longer appointment types. And so as that model was changing is when I got into my model, which is called direct primary care. So 2 years ago, I opened Health Studio KC. And the way we operate is it's all geared around a relationship. So it's membership-based medicine, meaning that when you need your physician, you can have access to your physician. We'll talk about that more. But it's really about knowing your doctor and building a relationship and having somebody that you can work with on your health. And so that's what I'm doing now. I'm doing that in the middle of KC and absolutely loving it.
Well, that's a question we're going to get to later about, we tend to think that private doctors, as I call them, are for the rich.
Yeah.
And I think that many of our listeners, including myself, didn't know that there was a whole slew of alternatives than rushing into the ER and going to see the doctor, which is a question later in here. But before we get to that,
Yeah.
first and foremost, why do we have health insurance in America? And what did people do before health insurance?
Yeah. So before health insurance, everything was what we call fee for service now, which just basically means you needed something from the doctor. You would pay the doctor whatever amount of money for that treatment. So there wasn't insurance. It was a direct. So maybe it was cash, or maybe you were paying with eggs or some sort of dairy or some sort of whatever services.
Selling your goat,
That's right.
whatever it
That's
was.
right. So we were trading services. And that's how it was for the majority of time. Then around the 1900s is when that started to change. And basically, it was in the 1920s, really, when insurance had started the late 1800s. The idea of disability insurance kind of moved into this idea of health insurance. So hospitals were the first people. They would offer prepaid plans.
Mhm.
And that was the origins of what was Blue Cross and now has become Blue Cross Blue Shield.
So almost like layaway for health.
Yes. We're going to do a prepaid plan, and then when you need it, you can use it. And it would be at a discounted rate by prepaying in that way. Then in World War II is where the employer-sponsored programs started happening. So the labor market at that point is what drove all of this. So what you had is the government had placed wage and price controls on all sorts of industries. And you had a limited number of employees, labor. And so how would you go get the best labor? Since you couldn't offer more from a wage standpoint, you can now begin offering health benefits. And that's where they started building out these health insurance plans. Were there to try and attract workers. Then you advance a little ways, and Truman was the first one to kind of bring the idea of the public insurance plan to the conversation. That did not go well. Everybody rebelled against that conversation. But health insurance really rose from 1940 to 1960. That's when there was a 7-fold increase of people on private plans. So you went from 20 million people to, by the end of about 1960, 142 million people were on some sort of private health insurance plan. Almost all of them were employer-based. So by 1958, I think the stat was 75% of Americans had a private insurance plan. So that's a pretty fast uptick. 20 years where we go from nobody to everybody, for the most part,
Wow.
having some sort of a private insurance plan. And that was all driven by employers.
Why do we so let's talk a little bit about modern times.
Yeah.
Walk us through how health insurance actually works
Mhm.
for your average American. And, do I have to have it? How do I get it? How's the pricing work? Kind of break down how this thing's supposed to work.
Absolutely. Oh, let me talk about one more thing on that employer-driven
Okay.
piece. Is that so now currently, employer-sponsored plans, the employer pays 85% of your premiums, and we'll talk about
Mhm.
what premiums are of their employees, and they pay 75% of their dependents' premiums. And so, when you from 2001 to 2007, there was a basically an 80% increase in premium costs.
Wow. What's that attributed to?
Um, Healthcare got more expensive.
Okay.
Is the biggest thing. And we'll talk about healthcare costs, I think, in a little bit. But, over that same period of time, there was only a 17% rise in inflation, 19% rise in wages. So it far outpaced what was going on. So employers are now feeling all of this burden.
So for the average American worker, how's insurance supposed to work? Like in
Yeah,
a vacuum, if I'm an economist looking at this, how's
yeah,
it
absolutely.
supposed to work?
Uh, if you're an economist, you're saying it's not very well. But I think that the way it's supposed to work is health insurance. Part of the problem has always been viewed differently than all other insurance. If you have homeowners insurance or car insurance or what have, insurance is there for when bad things happen. So something bad happens, then you trigger into your insurance. The small stuff, I mean, like for your car, you get your oil change, you pay for that cash wise. The maintenance things you pay for. But, if a car accident happens or what have, then that's where insurance kicks in. We've never really treated health insurance that way or not very well. So we've always believed this health insurance plan is a right. And once we give that to you, I'm covered. I've made my healthcare decision, and health insurance should cover everything. Preventative care, it should cover the bad care, hospital care, everything. And so what that has done is also it takes responsibility away from us. And the problem is that initially those plans did cover everything, but over time, as they've gotten more expensive, they cover less and less and less, and it gets way more complicated in terms of okay, what do they cover? At what percentage? If I go for this service, are they going to pay for it? How do I get access to that service? It's gotten pretty ugly.
And who decides what benefits get put in for what pricing amount? Who makes those decisions?
Yeah, so the insurance companies, so they'll make the decision, and then after they've crunched all their numbers, then they decide these are the plans we're going to offer, and then an employer will meet with a broker and then decide which plans to offer. Small companies will maybe offer one, smaller to medium size, maybe two. And as you grow, there's usually a number of plans that become available. And I think we're going to talk about that breakdown in terms what are all the things you should be looking at in your health insurance. But if you have health insurance, you should always be asking what is the cost for whatever the service is. And the hard thing is if you're going to insurance, it's usually not a straightforward answer. If you have health insurance and you ask your doctor, how much is this going to cost? And they say, I don't know. They literally don't know. Most of the people in their office probably don't know.
Then how do you get to an answer?
A lot of wait time on the phone.
Okay.
Eventually, you can get somebody in the insurance office to break down and go, okay, this is where you're at with your plan, your deductible, your what have. We'll pay this percentage up until you hit this. And for that service, we've decided that we'll cover 30% or 60% or 100%. And it's a lot of matriculations to get to that point.
Was insurance meant to be used in a very specific way? Walk me through. You talked a little bit about, it's supposed to be for when things go bad.
Yeah.
But how am I supposed, what's the optimal scenario? Like, what does my life look like if I'm using insurance the right way?
To me, as a solution, I believe that using insurance the right way means that you should use your health insurance the same way you use all of your other insurance. The really bad stuff. You get hit by a bus. That's when insurance can kick in. What we need to do is then take back responsibility for the healthcare costs for the maintenance stuff, which we can do way less expensive by just paying cash and reintegrating a fee-for-service model. And that's what direct primary care does. So what I do is by having this monthly membership, so $60 a month, I'm your doctor. There's no copay, there's no hidden costs, and what I really push towards is having full price transparency. So, for instance, somebody hurts their knee, they come in and they see me. If you're going into a traditional practice, that doctor has to see 4 to 6 people in an hour. So they've got maybe 5 to 10 minutes with you at best. They're going to hear the story, look at the knee and say, okay, well, we can get an MRI and move on. Is that going to fix it? No. So there's a whole conversation on how we should be doing healthcare in a way that's more practical, better outcomes, less expensive, by actually having time with your doctor. And then if you decide, hey, there is an MRI, well, the question is, what's the insurance going to pay for it versus what could you do cash wise?
Right.
We've gone out and negotiated cash-based prices because they make, the hospitals and the radiology places make money when their machines are humming. They're also only going to get a small percentage of whatever insurance charges. So they look at that and they say, okay, whatever that percentage we're going to get, if we can not deal with the hassle, we'll give that to you with a 10% discount or whatever, cash-wise.
So this isn't like a payola backdoor kind of deal.
No,
It's a
no.
legitimate
It's totally
thing
legit.
to be able to pay cash.
Yeah.
Okay.
Absolutely. Even if you're not set up with a direct primary care physician like myself, you should be able to ask what the cash-based price is. It's going to be more than what I can get access for, but it's going to be a lot less. So if you're talking an MRI is going to be $2,000 to $4,000, there's a potential that you could get that down in the hundreds of dollars, depending on what the situation is. That's across the board with a lot of what we do from a healthcare standpoint. So how to use your insurance well is one, to choose the right insurance for yourself, which I think we'll talk through options there, but two, then to ask a lot of questions and don't just agree to move forward. Hey, is this the right study? And then how much is this going to cost? Who do I need to talk to find out? And you're probably going to have to do some legwork of that on your own.
Well, and I think it may be intimidating for a lot of people out there. You're sitting across from a doctor
Yeah.
who's clearly more educated than 99% of the population.
Well, at least in that field. Yeah.
And, I feel like that's something where we sometimes don't feel comfortable
Yeah.
in saying, what's the cash price? Is this necessary? Why am I having to take these drugs?
Yeah.
Those types of things. And it seems to be a recurring theme I hear from people in the healthcare industry is educate yourself.
Yeah.
Don't just blindly go into something and figure it out the hard way. There's enough education out there. You can learn about this stuff.
Well, and that all comes back to having access to a relationship with somebody you can trust. So if you're going to an office where, one, it's really difficult to get into whoever you typically see, so you end up seeing whoever is there that day, the likelihood of a good decision coming out of that decreases incrementally with each of those layers. You put stuff off longer because it's harder to get in, and then when you get in, there's not a conversation. And so by being able to have a conversation, now you can start making informed decisions, and we can hopefully be providing transparency so that you can be making those informed decisions too.
In my early life, I made the mistake, and I know friends and people out there that make the same mistake, that anytime something goes wrong, we run to the ER.
Yeah.
And I've watched firsthand what that does to you financially. And, it's not immediate effect. You don't walk out with a bill immediately, but if you did, we might not do it as much. It's not till, 4 or 6 months down the road do you get that ER bill where all the rates are more expensive. Everything was more expensive. And, I love to go through a rapid fire round with you of questions and have you answer one of a few things. I'm going to list out a list of items that are potentially wrong with me.
Yeah.
And you tell me whether I should stay at home, whether I should make an appointment, I should go to the ER, I should go to urgent care,
Yes.
or do something else that you fill in the blank with.
Great.
Okay, so rapid fire round. I have a cough but no fever.
You should try and take care of it with something over the counter.
Okay.
Or if it's been bothering you long enough or you're not sure what to do with something over the counter, go ahead and call your physician, your primary care, and they should be able to make an over-the-phone recommendation for you.
I have 103-degree fever and I'm scared.
Definitely call your physician if you're scared. If you have 103 fever, regardless, take something, Tylenol or ibuprofen for it. This is if you're able to take those, blah, blah, blah. But start with trying something simple over the counter. The number of times people come into me, well, have you tried anything? No. Okay, let's try something. And then if it's not getting any better, feel free to give us a call.
I broke my leg riding a motorcycle.
Yes. So this one, I should say for all of these, I'm probably going to answer call your primary care physician first, with the understanding or caveat that when you do that, in my system, you get a hold of me. If you do that for most people, doctor, you leave a message and you will not hear from them for a couple of days. So in this situation, if you're my patient and you do that, you call me. The reason why is I'm able to get the right x-ray for the right price and get you to the right orthopedist at a cash-based price and avoid the ER costs. All of those things I can do and I'm willing to do. Typical physician, you call, they're going to say, go to the hospital now. That's something severe. You could certainly start in an urgent care. And depending on the level of the urgent care, if it's physician run versus PAs and NPs and things like that, there can be they should be able to make a decision of if they can treat it or if they need to send you to the ER.
I have blood in my stool.
Call your physician. Not urgent. You don't need to go to the ER for this.
That's an interesting one because most people think that's like the pinnacle of I'm dying.
Yeah. No. If you're not having any other symptoms with that, the likelihood of it being something serious is very, very minimal. Don't go to the ER. I would say don't go to the urgent care. Again, having a relationship with the primary physician, call us.
I have pain when I urinate.
That one you should address either with your primary or an urgent care would be fine. Do not go to the ER.
I think I have an STD.
Same. If you can get a hold of your primary and do that or an urgent care, both of those, you should address that as soon as you can.
I think I have pink eye.
The majority of pink eye is viral. You can start with an over-the-counter eye drop and see if there's any benefit there. Stay home because it is like wildfire. So it goes everywhere. If it's not getting better in 12 to 24 hours, if it's getting worse over, let's say, a period of 24 hours, call your physician.
I don't think my prescriptions are working the right way.
Definitely call your primary. Do not go to the urgent care. Full disclosure, I work at an urgent care on Saturdays. My kids go to a wonderful private school. It's not free. So I supplement with that. And the urgent care is the worst place, particularly for a long-term conversation like that.
I need a medication refilled.
Also, call your primary. Now, I do understand on the weekends that there are a lot of primary docs that will not take call on the weekends. They should have somebody in their office that could help out with that. But if you run into all of that, you can go to an urgent care. It depends on the medication as to whether or not they're going to have any comfort level with refilling it. At the end of the day, look at your pills, be a responsible adult. And if you're starting to run low, call your physician when you've got 5 pills in the bottle. Don't wait until they're 0.
I have high blood sugar or extremely high blood pressure.
That would be something to call me or be seen immediately. Urgent care would be an okay place to start with that if you're not having any other symptoms.
Okay.
And they could get you directly to the ER if necessary.
My child has a cough. I'm sure you hear a lot of this.
Yeah. I don't ever mind that phone call. But I also do encourage people to, like, have you done anything for it? If you have a cough, no fever, I would definitely give that some time and try a few things, maybe some allergy meds, maybe something from a cough standpoint. But yeah.
My child has 103-degree fever.
Give them some Tylenol or Motrin. See if it comes down. If there's no other symptoms, this is for children that are over 6 months of age. If you're under 6 months and you have that high fever, you need to be seen. But over that age, try something, and then feel free to give us a call and let us know what's going on.
It sounds like to me from that lineup, unless you've been impaled by an object, you've been shot, or you're certain that you're dying, you should be either going to an urgent care or setting up a appointment with your primary care doctor.
So here's the deal. I mean, urgent cares are probably the fastest growing subset of the business right now. They're everywhere. You're right. ERs. So an ER is their emergency room. Emergencies are things that potentially you're going to die from. And they are really good at that. If you're going in with some generalized symptoms, a little abdominal pain or a little bit of a headache or a little bit of these sorts of things, you're going to walk out with a huge bill. And they're not the right people because they're not very good at necessarily treating those sorts of things. They're going to answer every question with, you need a CT scan or an MRI or some other expensive, because those are the tools that they have at their disposal. It makes sense. That's what they do. So if you go there looking for a certain thing, but it's not within the wheelhouse of what they do, you're going to leave frustrated and with a really big bill.
Let's talk cost a little bit more. What
Yeah.
happens if I'm a ER person?
Yeah.
I always go there for everything. And how long does it take for me to get the bill?
Yeah.
What does a ER visit typically cost if you know that information? And what happens if I just can't pay it? I'm just broke.
Yeah. So ER costs, an average visit, I think, runs kind of right around $1,200.
Every time you step foot into that ER, you're going to, at minimum, be spending $1,200.
Minimum 500, but I
Okay.
would say on average, you're going to walk out and, it would be a $1,200 bill or something along those lines.
Okay.
Now, some ERs have urgent cares associated with them, so that billing is different. But even if you come see me at the urgent care on the weekend, cash-wise, before I do anything, it's $150. Now, if I order a test, strep test, or we test your urine, or we do something else, like that's another $30, $50. All of these things layer. We get an X-ray. There's a couple $100. And so all of these things begin to layer, but the ER starts with the highest first in price point. By far the most expensive. You're not going to see that bill for probably a minimum 3 to 6 weeks. And then it's going to be full of all sorts of confusion within it as to what everything has been billed out for. And so that's pretty difficult too. Now, what happens if you can't pay that? There's options. I mean, one, hiding is the worst option. You can call.
They will always find you.
Yes. And you can talk to somebody there in finance, and sometimes they can negotiate out a different cash base price for you. So that's a possibility. But the reality is, people that talk about universal health and other things, like at the end of the day, if you can't pay that, we all pay for it. Whether the ER absorbs that and then the government subsidizes it, or the ER absorbs that and then they increase the cost of everything else for the people who can pay, we all end up paying for that visit. It's the least efficient and most expensive way for you to get care. And we've decided that it's the best option because we don't want to provide other options.
I heard one of my former employers had told me never pay in full on a medical bill, even if you have the money, because if you can call them, they all have payment plans.
Yep.
Some are standard at 12 months.
Yep.
Some will go up to 24 months, depending on your hardships. But, why go spend $5,000 in cash when you can spread that over 12 months from your own personal home?
Yeah.
Cash flow standpoint, it's a much better option. Would you agree with that?
Absolutely. You should always call and ask what they can do for you. And they want to kind of work with you and get whatever they can out of the situation. They're not, wanting to put you into collections or do other things like that. But, they're also running a business. But the billing of medical billing is crazy. I mean, if you came to the coffee shop and said, I'd like to order a latte, and they're like, okay, that could cost anywhere between $4 and $400. We haven't really decided. And it might take 5 minutes or it might be ready for you in 12 hours. And we'll go ahead and bill you in a couple of weeks. Now, do you want that latte?
Right.
I mean, so we work really hard in our office to try and give people a straightforward cash understanding of something. So let's say screening mammogram. So there are offices in town that'll say, hey, to do the mammogram costs $180. But if we do it and then we decide there's something suspicious and we want to do an ultrasound at the same time, then we're going to charge another $180. And then if we need to do an additional service, so there's layering on of being unsure if we add things, what do we need to do? The office that we most recommend to in town just does a flat. They say, hey, listen, no matter what we do today, it's going to be $200. So it might be a little bit more up front, but there's no add-ons. There's no guessing game. There's no trying to figure out, oh, okay, am I going to leave the office today with a $180 bill or a $500 bill? So that's what I really lean towards, is trying to find, okay, at the end of the day, what's the total cost, so I don't have the nickel and dime charges. I mean, it's the same reason why people fly Southwest versus all of the other carriers.
Let's talk deeper about cost. Why is insurance so expensive why is my out-of-pocket cost always so expensive? At least in modern times, as
Yeah.
factually as we can be.
Um, well, our healthcare insurance is expensive because healthcare is expensive. We have by far the most expensive healthcare in the world. Um, the Commonwealth Fund came out with their rankings last year of what's the best healthcare in the world. And so, looking at kind of 11 industrialized nations, we are number one in expense. So, we're by far the most expensive. We were number 11 in quality out of 11.
Wow.
And so, what were they looking at? They were looking at care, the care experience. They were looking at access to care. They're looking at administration efficiency. How efficiently do we do the care? The equity of the care and outcomes. And we were fifth in the care experience, and we were 11th in everything else.
Do you remember what number one was?
I'd have to look it up.
Was it a socialized medicine or non-socialized?
Yeah, I mean, of the other 10, they were almost all socialized.
Okay.
I mean, you're looking at European nations, Australia, Japan.
Would you contribute? It's a thing that's sat in the back of my mind when somebody says, I hear a stat like this. I
Sure.
immediately think, well, we've got 300 million people here, and to say that Finland has better insurance than, the United States, okay, go make it 20 times bigger and tell me if it's still the same. Is scale part of our problem, or?
Scale is a small part, and probably less scale than it is the breadth of our economy. So I would say that we have a higher number. We have a greater economic gap. So our 1%, like the gap between our top and the gap between our bottom, is wider than most of those countries.
Okay.
And we probably have a larger percentage of people on the lower end of that number.
Okay.
So that makes, the whole reason why Medicare and Medicaid came to be was the people that need the care most are the people who are least able to afford the care. So you talk about elderly, you talk about those that are in poor, impoverished situations from a nutrition standpoint, access, sleep, all those sorts of social economic pieces. Those are the people that are going to most likely need the care. They are the people who are most likely able to afford the care. So that puts a burden on us. But also, we just do healthcare way more expensive. And so, as you
And it's not doctor salaries, right?
no.
I mean, because that's what everybody says. Oh,
No.
doctors are getting
No.
paid, and the rest of us are dying out here.
So when you talk about that comparison, our I think we run right around 17 to 20% of GDP in America is healthcare business.
Wow. So 20% of our overall gross domestic product,
Yeah.
our output, 20% of that is healthcare.
In all of those other 10 countries, so if you talk the scalability piece of their GDP, it's usually less than 10%. So it's half of ours.
Okay.
So that helps with the numbers piece a little bit.
Okay.
I think that, our healthcare last year was like $3 trillion. Basically, our healthcare alone would be the 5th largest economy in the world.
Wow. If we were only on healthcare.
If we were just doing healthcare, the healthcare costs, that's the 5th largest economy in the world.
Well, someone's getting paid in this process.
Yeah. But, why is it so expensive? So one of these things that we just talked about here, number one, administration costs. The number of people that we have to pay to decipher, because every insurance plan has a different set of instructions, different flow chart as to who gets paid, what they get paid, how they get paid. And so each office employs a whole industry of people that's all they do. So a typical, for example, a typical family physician, if I was to go out and open an office in the typical way that people do it, I would have to hire probably between 2 and 4 people just to do billing in my office.
Just to bill people.
Just to bill people.
Which is a go-between insurance and
just to
your
do the
patients.
billing.
Okay.
So I'm paying a salary to those people. In my office right now, it's myself and my nurse. We're the only two. So we're not chasing out all of the billing stuff because we don't do insurance. And so administration costs are huge, total confusion. I mean, we're not just confused when we look at this. The offices are confused when they look at it and they put it out there. So our admin costs are significantly higher than anywhere else because if you're looking at obviously socialized medicine or what have, it's all straightforward. What does it cost? This is what it costs. Boom, done. So that's one of the huge reasons why healthcare is so expensive is just admin people costs. Second one can be drug costs. Drug costs are very, very high. Most countries will limit the scope of what's available. They'll negotiate it out from that standpoint.
And do we not have anything in regulate? Because we hear a lot of stories on the news about, this AIDS drug now got jacked up from $30 to $3,000 or whatever the numbers are. We hear that a lot. Will we not have any regulations saying you can't do that?
Correct. So do you know who gets the cheapest drugs as a group, if you talk insurance and everything else in America?
No telling.
Medicaid. They're the only group. Well, they're the only government group. So Medicare can't even negotiate. Medicaid can negotiate with drug companies to get prices. They get the cheapest prices of anybody. So, because it's a government entity, they're huge. If the government was able to come forward and say, we're going to start negotiating. So like New Zealand, they'll go to the drug companies and say, hey, no advertising. You're not going to advertise. We're going to pick a formulary. These are the drugs we're going to use. Great. I mean, it's what Warren Buffett does with Nebraska Furniture Mart.
Sure.
We're going to buy these things. These are the only things we're going to have. How many of them? What price can you give me?
Well, and it seems like over the past 10 years, we've seen it. The costs have skyrocketed. Everything's changed. Is it a fair assumption to say, I feel like I've watched insurance companies, they had no idea what was going to happen with the Affordable Care Act and then what was going to happen after. So there's a lot of weirdness in the process of like, we don't know where this is going. So you know what? We're just going to keep boosting 10, 15% of the year, not knowing where we're going to go. Is that part of it, this huge level of uncertainty about what their expenses are going to be?
It certainly is a part of it. I think there's the fact that one, it's just expensive. And then two, it's the unknown. Certainly they're trying to figure that out. They also don't want to deal with it. I mean, they make a lot more money doing it the way they have always done it than having to do it differently. So the other things you look at, people talk about, say, defensive medicine. Is that really a part of it? I don't know if it's defensive medicine as much as because there's tort reform and there's ways to protect doctors. And that hasn't always shown a big decrease in cost.
So you're talking about the argument that some people say, well, if our law system was different, it wouldn't be so expensive.
If we didn't live in such a litigious society, would people practice medicine differently? If somebody comes in with a headache to the ER, like we were talking about before, they're almost always going to get a CT scan or an MRI because of the 0.0000001% chance that it's a brain tumor. And so headaches and migraines, is it necessary to have an MRI? No. But you're going to get that study, an expensive study, because of the possibility that it could be something, and we don't want to get sued or miss something. That's the basic idea. Does that happen? Absolutely. Are people afraid of that kind of litigious activity? For sure. And so there's legislation out there that tries to help some of that.
Okay.
And so the question is, would that help as well? Maybe. But here's a different thing. I think that the other thing that we do as physicians sometimes is we rely on our technology in certain ways too much. So I had a patient that came to me, and he was yellow, like highlighter yellow, and young guy. And so he had some things going on with his liver. His bilirubin was very, very high, and he didn't have any of the common reasons to have things going on with his liver, so it was hard to determine what was going on. He had first gone to an urgent care. They didn't know what to do with him, and they said, you need a CT scan. And so they were willing to order that and then pass him off. And then his next step was going to be to go to an ER. So in the midst of that, he heard about me. I said, well, come on in. Let's see you. He brought his labs that he'd had done. We took a look at all of that. As I sat down, I realized I don't really think that getting an MRI or CT scan is going to be that useful for me information-wise. An ultrasound, much less expensive, could tell me what I need to know to start with. So we started with that. Then The next thing to do would have, in theory, been a liver biopsy. Well, the least expensive cash-based liver biopsy I could find was about $2,500. This is a guy that was working as a bartender, um, and so that and didn't have a lot of savings. So $2,500 for a biopsy to tell us what, in theory, might be going on, not treat, was in theory the next step. But I looked at it and I go, listen, we've ruled out all the other stuff for about $70. So it makes the most sense that it's this odd inflammation reactive disorder that a $5 drug could fix. So then I called a liver specialist, ran that by him, said, hey, this is what I'm thinking. Does this seem reasonable? And he goes, as much as I'd like to get a biopsy, I agree with you. I think that's reasonable. We put him on the $5 med and he was better in 2 weeks. Had he gone through the traditional system, had he had insurance, that would have probably ended up being a $5,000 to $10,000 experience, of which I don't know how much insurance would have covered.
And if you were a normal doctor where you didn't have the time and you were seeing 5 patients,
Yeah.
you'd do that because that's what you got to do to stay
That's what you got
efficient.
to do to stay efficient, to get cranking through stuff and everything else. So that's an extreme case, but that's one of those things where we order things too quickly. If for a shoulder, people will call me and say, hey, I hurt my shoulder, I need an MRI. Well, do you want surgery on your shoulder? No. Okay, so we probably don't need the MRI. What we may need to do is some physical therapy.
Right.
You know, it's similar that a drug is always easier than making lifestyle changes. Getting expensive radiology is easier than going to do the hard work of physical therapy or something else like that.
We do like to avoid our pain in America.
Yeah, it's time, man. And so that's the I think one of the reasons why healthcare is so expensive is that we do a lot of that. The other one is duplicate medicine. You know, there was a study that came out a couple years ago that said basically there's $700 billion in medical waste that occurs, and that's inefficiencies. So that's different electronic medical records not communicating with each other. That's even in the hospital. If you've ever, you look through a patient chart, and so all the different specialists come and see the patients each day, and then they write down what needs to happen. And handwriting is abysmal. It's gotten to where most of them are now having to type it in and things like that. But there was a long period of time where I don't know what he actually or she wanted ordered today. And are we duplicating what needs to be done and all that kind of stuff. So
that's the reason why someone like Cerner is skyrocketing right now.
oh, sure. I mean, they're really trying to attack that medical waste
Okay.
by integrating services and doing things along those lines. But I mean, that's, $700 billion.
And we're not talking about medical waste under trash. We're talking about inefficiencies in
In the system.
operations.
Yep.
Okay.
But now we're getting into the things that I really am passionate about is the fact that our healthcare system is inverted from the rest of the world.
And that's a fact.
yeah.
That's not your opinion. That's a
I
fact.
know it's a fact that primary care medicine for the rest of the world is where everybody starts. And then you end up at the specialists. In America, we have specialist first medicine. So frequently I'll talk to people and they'll say, oh yeah, I have this shoulder thing, so I just went and saw an orthopedist. Well, here's the secret. The orthopedist wants to do surgery. That's their cure for things. And so I asked them, I said, what'd they do? Well, they ordered some expensive radiology and told me to take some ibuprofen and ice. Is your shoulder better? No. So they had spent a lot of money on the specialist visit and on radiology and still had shoulder issues. We go straight to specialists for things that we don't need to go to see specialists for. It's the most expensive way to do medicine. So the rest of the world starts primary care and then moves their way down. And so that's the way it should be. I kind of look myself as being the quarterback of getting you to the places you need to be if this isn't the right spot. If I can't handle it, then who needs to see it? So the interesting data, Q Alliance is a huge direct primary care group out in Seattle, and they took 2 groups of people, 2,000, I think it was, 2,000 each group. They had the same insurance plans, but one group had access to a direct primary care doc and the other group didn't. And they looked at the insurance claims data after a year. And what they found was fascinating. Basically, there were 70% fewer ER visits for the group that had the DPC doc. There was 80% fewer surgeries, 66% fewer expensive radiology tests. was thinking there was one other. The only thing that went up is there was a 92% increase in people seeing their doctor.
Hmm.
So huge cost savings, because when you have time with a direct primary care doc to sit down, you avoid all of this other stuff. Our healthcare system is not geared that way. You've got hospitals buying everybody up and saying, hey, you need to see 4 to 6 people. You get 15 minutes with that patient, go.
But it's in our power and our control to change that scenario for ourselves, and we're not stuck in this scenario, right?
Well, it depends. If you choose to have a direct primary care type physician, and we're grow and breed, then yes. But if you're going to the doctor and expecting to get more than your 8 minutes, that's not
It
in
didn't
your
happen.
control. In Kansas City, the average visit is a 2-hour experience for which you get 8 minutes on average with the doc. So that's the rest of it's
I
drive
will
time,
say,
waiting room time, shuffled around
as
time.
a transparency, I'm a customer of yours and have been for quite some time, and that's what's changed my mind, which has even gotten us to this healthcare conversation, is for me, when running a business, going to the doctor is like the second most painful thing behind going to the dentist.
Yeah.
And, going to the dentist, while that cost isn't out of control, it's just an anxiety thing.
Yeah.
But, for a doctor, it's like, man, I got to, schedule 6 weeks out. I'm going to have to go wait for 2 hours,
Yeah.
twiddle my thumbs, take time away. And working with a direct primary care private doctor like yourself, you literally have an appointment that you can text you about, and then I show up and you're like ready to go.
Yeah.
I mean, it's like a 15-minute experience
Yeah.
in and out, and that alone is just
Yeah.
absolutely incredible.
Yeah. And that's if you need to come in. A lot of times it's like, oh, this is going on. I call you quick. We say, okay. And then we treat you. So all of these are reasons why healthcare is so expensive, and therefore health insurance is so expensive. I'm not going to sit here and say that they're making a ton on the margins. I don't know what they're making. And they have issues with their own litigious stuff. I mean, I was talking to somebody who works fairly high up, local Blue Cross Blue Shield. They had to add one line in the contract that was a repeat of other things that they had said earlier in the contract. One line, but they had to print it in 110 languages. It ended up
Wow.
costing them a couple $1 million just to add this one line to all of their contracts.
Well, and that's an important thing to know, though, is that while we had this conversation about being expensive, it's not necessarily fair to go point the metaphoric gun at somebody
Yep.
because everybody's in this scenario and there's not really a clear answer depending on where you are, insurance, doctor, in game of where they can just go, oh, we can just change everything and
Yeah.
it fixes it. I mean, everybody's in
It's
this problem.
super complicated, and nobody is totally killing it. Our biggest issue is just getting over it. Well, this is the way we've always done it, AKA over the last 100 years. So getting people to move beyond that into something that might feel a little bit uncomfortable, but is something that could potentially be a ton better. One of the reasons I did DPC is a family physician in the community makes 20 cents on the dollar. By the time they pay for all their staff, by the time they get crappy reimbursement from insurance, that's why they have to see 40 to 60 people a day. I can't even imagine doing that, to make ends meet. And, in the DPC scenario, I'm making more 80 cents on the dollar.
Wow.
So that totally shifts the type of care I can provide. Completely. And if you talk about, well, are there enough docs out there? I've known in the last year 5 physicians retire that are young. They just got out because they hate their life. So the biggest problem is we're losing doctors all over the place, or people are not going into medicine. If you're going into medicine to make money, you made a poor decision. So it's, this is also a solution to give people a life back. So it's good on both sides.
Which seems to be a common theme on EX5 about having a well-balanced life and whatnot. You mentioned earlier Medicaid versus Medicare. I
Sure.
think a lot of times we mix those words up. Can you explain those two for me?
Yeah. So Medicare was created for people over the age of 65. So it's care that was created for the elderly. At that time when it was implemented in the 1965, it was premiums for the elderly were 7 times the cost of a young person.
Wow.
So you have somebody who's at the end of their earning potential or no longer earning, paying 7 times the cost just to have insurance. that, by the way, was not as good as the insurance was for the younger people because, that's the most expensive needs that they have. And so the government saw that and said, okay, we need to do something about
Does Medicare change based upon my income level, or is it equal just because I'm an elderly?
it. Medicare's equal.
Okay.
And I mean, we're all paying towards Medicare.
Okay.
You and I are paying towards Medicare. Tax dollars go towards that.
Okay.
So you're paying for it throughout your life. And hopefully, I have,
Hopefully it's still there.
yeah, who knows? But yeah. So that's how Medicare in general works. Is
Okay.
it's to help supplement that care. Now that'll supplement a variety. I mean, they can still have individual insurance plans and other things like that, but it's the government trying to help.
So Medicaid.
Medicaid is for poverty. So Medicaid traditionally had been you had to make less than 133% of the poverty level to qualify. So in 2018, I looked this up. Federal poverty level was for an individual $16,146 a year.
Okay.
And so you needed to make 133% of that. So basically less than $20,000 a year.
Okay.
For a family of four, that was $33,000 a year
Wow.
was the poverty level. So if you're making less than that, or if you're permanently disabled, you also can fall into Medicaid does that. And there's a couple other conditions, end-stage renal disease, because dialysis is so expensive, ALS, that also qualify. But you have to qualify in that way.
Is that then, because I know there's a lot of state interaction
Yes.
with Medicaid. So
Yes.
what's the if it's equal for Medicare, what's the kind of spectrum for Medicaid?
So for Medicaid, it gets, and this is probably getting beyond my knowledge, but it does really where it varies is how the state handles the funds and how they interact with the government funds. So one of the big things on the Affordable Care Act was to expand Medicaid to more people, to increase that 133, I think, to 138, to provide additional benefits at varying levels for people to give more access. And so, but you had to opt in to the program in order to do it. I don't think Missouri or Kansas opted in. The states that did opt in, there's a majority that did, have seen a higher decrease in overall costs for healthcare. So it's worked in that way. I mean, if you talk about, it's hard to talk about the cost, but the big thing that the Affordable Care Act was really trying to do was get people coverage. In 2010, before it was instituted, 16% of Americans, somewhere in the 16 to 20, depending on where you read, were uninsured. 6 years later, in 2016, that decreased to 8% of Americans were uninsured.
Which, to recap on that, prior to the Affordable Care Act, you didn't have to have insurance. And today you don't have to have insurance, but there was a mandate put in place of the Affordable Care Act that basically said everybody needs to be insured, just like cars. And in your state, you want to drive a car, you got to have insurance. Now, the problem was because costs skyrocketed, a lot of people just chose not to. You face a penalty for doing that. But now that that's been ripped and peeled away, you're back to the place where you don't have to have it necessarily, correct?
Correct. And that same thing for employers. Was then the big pressure on employers to have it. If you have more than 50 employees, you have to have it as well. Here's the question. I mean, in this conversation, is healthcare a right? Is healthcare a privilege?
And that's a total, depends on where you are in your life, everything, right? No one can agree on that.
Yeah. And it's going to be informed by your experience. But I think that where we put our head in the sand is if we decide either way that we don't have to deal with healthcare. We all have to deal with healthcare. If you don't have coverage and you get hit by a bus, then you end up in the hospital. And I don't think you're going to deny care, but you can't afford that care. So we all are going to pay for that care. That top-bottom mentality, again, is the problem. We do healthcare the most expensive way. People end up in the ER for all sorts of the wrong things. And that is the most expensive and the least efficient and poorest outcome care that we could provide. So until we decide that we have to somehow do that different and better, um, because nobody's going to, uh, you walk into an ER, you get care, especially, I mean, if it's emergent,
And that's a fair assessment,
you're going to get care.
which is probably the natural draw to why we go to the ER.
Yeah. So that's where it backs up and we go, okay, so again, is this a right or a privilege? We're all going to run into that at some point. Um, no matter how healthy we try to be, how healthy we try to live.
If I just got started on Medicaid, I'm down and out. This is a new thing for me. Should I be ashamed that I'm on Medicaid? Are doctors going to look at me and just hate the fact that they got to run this through Medicaid?
No, no. I mean, there is this thing. So doctors will opt out of things, Medicaid, the same way that they'll opt out of certain insurance plans or what have. That has nothing to do with the patient. It shouldn't. I'll say that. It should not have anything to do with the patient. It has everything to do with the reimbursement and the hassle. And now I need to hire 2 Medicaid specialists to do billing to get fewer pennies. And it's all of that scenario. The hard thing with this, I feel like across the board, is there was a time in health where all hospitals would do a certain amount of indigent care. And it was, you spread the wealth. And everybody would do their 10 to 20% and help out. As hospitals became big business, 60s, 70s, and on forward, that began going away. And now suddenly you have teaching institutions in town, KU and Truman, become the only places, because they have residents that are cheap labor, that will do indigent care. So all the other
And what is
hospitals,
indigent care?
poor care, can't pay
Okay.
care. And so they say, you go there. And so instead of us sharing the burden, we place all the burden on 2 locations that are the 2 locations that are going to get the most government funds. And we wipe our hands of it and say we feel good about it. But no, you should never feel bad about having access to care in that way.
There has to be a smarter way to stay healthy and whatnot. Could you walk us
Yeah.
through some of the smart ways to reduce in the macro scale
Yeah.
my overall cost? And then after that, give me a little bit of info on, like what are the alternatives? And there's now telemedicine
Yeah.
and obviously primary care doctors that are direct. So let's hear the broad scope on that.
Yeah. Well, I'll touch on the last part first, and then I'll talk about the health part, because I'm really passionate about that on the second. So the first part, there are different access pieces out there. Telemedicine cracks me up. I know some people that do it. They sit at home in their shorts and tie at a desk, and they do this. But I equate it this way: if would my kids rather FaceTime with their grandma, Gigi, or would they rather hang out? What's the experience? What's the interaction? If you've spent any time FaceTiming your kids while you've been away, how pleasurable is that? It's absolutely miserable.
Right.
I've got 4 kids; they're all fighting for time. But whatever. I mean, it's a lesser experience. Well, it's the same
Right.
thing. It's a lesser experience, and so there are certain things that we need to look at. Like if you have ear pain, I need to see your ear. So is there a
Right.
device that you could hold up and I could look and that's sure, but touch matters. Face to face matters. It's
Right.
different care, and so much care that I see. So many of the things that are wrong with people are related to other things that they have no idea are going on, whether it's stress or lack of sleep or these other things. And these are not comfortable conversations to have. So there's a local restaurant here in town who I care for their people. And they had a telemedicine plan the first year. And it wasn't until they began seeing people having some issues beyond just like strep throat that they're like, oh, that is a very awkward scenario to have a telemedicine conversation.
Well, and to clarify, telemedicine is basically like FaceTiming a doctor that is regulated in your state.
Yeah.
So I hop on an app, I click a button, I'm
Yeah.
connected to Damon Heybrock. You could be sitting at your house, and I say, oh man, my ear hurts. He can't come put anything in your ear, but for the general level stuff, he may be able to say, oh, let's try
Yeah.
some antibiotics, which
Yeah.
some people will say is reckless, and other people go, oh, well, it fixed my problem.
Yeah,
But to your point,
it's another vehicle for urgent care medicine.
okay,
And not having to leave
great way
your
to put
space to do it. And to me, it's just a lesser. If you want to settle for the lesser, I understand. I understand why it exists. I just hate that it exists.
sure.
Um,
Because as a doctor, you're literally
Yeah.
de-romanticizing everything,
Yeah.
right?
Yeah. It's a different scenario that you're going to go ahead and settle for. Now, I mean, are there applications for it? Yes. Does Mayo do some amazing things with rural areas that have no access to doctors and utilize telemedicine in a cool way? Yes. So do I think that there could be a usefulness to it? Absolutely. But as the usual fallback, the I don't want to drive 10 minutes to see the doctor, my doctor sort of a thing, I hate it.
Well, and the other alternative that I've seen as I went back and looked at insurance programs is now there's massively reduced cost insurance programs where
Yeah.
it's literally like it's like getting non-full coverage on a car, right? Where
Yes.
it's like, and as I got a motorcycle,
Yeah.
I was like, I better find something.
Yep.
And both Aflac and now like Blue Cross Blue Shield and a bunch of other people now have options. It's
Sure.
like, just in case you screw up your life, we've got you covered kind of scenario,
Yeah.
right? So that's
Yeah.
changed in the last
Yeah.
15, 20 years.
Yeah.
Because it used to be all encompassing.
Yeah. Yeah. I mean, we're definitely dividing it out. I mean, it's the same thing you see at the airlines now. I mean, if you've tried to fly Spirit Airlines or what have, I mean, you got to be a ninja.
They're the butt of every joke, and
yeah.
I feel sorry for them in some way, but I've never flown them, so maybe
Well,
that's why.
I mean, they are what they are. They will fly you crazy cheap.
Right.
And if you know how to play, I have a friend who she knows how to play the game, man. She looks at it as a challenge and she flies all over the place. It would be miserable for me. So, that's why I fly Southwest. And they should sponsor this because I've mentioned them like 3 times. But
If anyone at Southwest is
shout
hearing
out.
this,
Shout out.
feel free to give us a call.
Yeah, so that's one version of care. Certainly, I mentioned urgent cares are popping up all over the place, and that's another way. And people end up at minute clinics and all of that. The thing you have to understand is when you walk in, like something simple. Somebody went to 1 minute clinic for poison ivy and got put on prednisone, which decreases the reactivity and effectiveness of your immune system as a side. And then they went to a different urgent care to get their flu shot, but they didn't have flu shots, so this was when the live vaccination missed, flu mist was being used, so they got the live vaccine missed while they were on the prednisone.
Mm.
They got a really bad flu. They gave themselves the flu with a decreased immune system. But because they went to 2 areas, didn't think to mention that, I'm on this prednisone for poison ivy.
Right.
And there would be no way for anybody to know, that sort of experience happens. When I see somebody in an urgent care, I'm dealing with this sliver of time. I know nothing of their history. And it could be a super complicated one. And especially if you're on 10 drugs, do you know all of them? Some people carry a list. Lots of people don't.
Yep.
So it's just a lesser care that we accept because it's convenient. I'm here to say that there's a way to have access, to have convenience with quality.
So tell me about the topic I know you're passionate about, because one's direct primary care and 2 about your relationship with the patient and the preventativeness. Because every time I hear somebody tell me, "Oh, eat right and exercise," right? I hear it as a bunch of hocus pocus and them just being a jerk to me because they're not validating my concerns. But that's what I hear all the time is, well, if you just ate right and exercised, it will solve everything for you. Great, I know that, but I don't. So let's talk about what you're passionate about.
Yeah, I think one of the worst things a physician can say, and it happens all the time, is, "Hey, buddy, you need to exercise." And then they walk out the door and they say goodbye.
You're like, thank you for that enlightening moment.
Yeah, I appreciate that. That was dumb. I mean, it's useless to say that kind of thing. Eat better. Doesn't matter, yes, but that's too simple of an answer. I mean, I really believe, hey, there's a way that our bodies are designed to operate most optimally. There's a balance and a tension in all of that. And when we get out of balance and out of tension, then that's when we have problems. You think about the bow and arrow and everything else. The only way to make progress is to be in proper tension. And so that's a part of these foundational concepts. It is how we eat. It's how we move. It's how well we hydrate. It's how well we sleep, how well we rest, what our passions, what we create, and how well we relate. All of those things, that's the foundational piece, and that's what matters. And if you're as the better we are at keeping those in balance, then the better our health is going to be. Now let's take one of those concepts, move, the exercise piece. There's a reason why someone is not exercising if they're not exercising. Is it they don't have time? Is it they're tired? Is it they don't have cost? Is it they don't have the knowledge? So my job is to sit down with you and to break down what are the barriers And then, or I just hate exercise. Okay, then let's figure out a different way to move. But to begin to understand what the barriers are, how do we get beyond those, and then to have a goal that we're working towards. I talk to people all the time about health goals, and we're goal oriented in all the other parts of our society, but health goals, what's the most common answer I get? I want to lose 10 pounds. That's what almost everybody says, whether they need to lose 10 pounds or not. Why? Because we all think we need to. We think it's achievable because there was a period in our life where we had lost 10 pounds, maybe accidentally. And so it's an easy thing to say. We lack total imagination around our health.
Right.
And so to sit down and talk about, okay, what are the goals that I have for a year from now? And how do I want to feel in 20 years? Because the decisions I'm making today will directly influence how I feel in 20 years from now. Then breaking that down in these items and starting to look at, okay, how well am I hydrating? What does that mean? Sleep is huge. 100 years ago, we slept on average an hour and a half, almost a full 2 hours longer than we do now. That has, for heart disease, what are consequences of
I
that?
mean, I do that on a regular basis, but I'm different. So,
you have a 5-fold increase of risk for heart disease for every hour outside of the optimal sleep window that you're getting.
wow.
So our American average sleep is out of the optimal window now. We average about 6.5 hours per individual. That has huge ramifications on your hormone production, on inflammation in your body. And so, again, sitting down and trying to decide sleep. The American way that we sleep is we push hard to the end of the day and then expect we're going to collapse in bed and be able to fall asleep. It's amazing how many of us don't sleep well. And then we wake up the next day overwhelmed because we just crashed after pushing hard to the end of the day. So shifting our focus and our mindset to unwinding at the end of the day and preparing for sleep. The Hebrew concept of the idea that the day begins actually the night before. In Genesis would always say there was night and there was day, the first day. So sleep, rest is the first part of your day that prepares you then to have the second part of your day. That's a whole mental shift in terms of the way that you're navigating your health. So for each of these, it's kind of beginning to break that down. Not everybody should eat the same. The way you may operate most optimally food-wise may be very different than me. Maybe intermittent fasting is good for you. Maybe you're okay on sugar. 75% of people out there, if I take gluten out, are they going to feel better? Yes. Does that mean that they're intolerant? No. Gluten gunks you up, just makes you feel off.
But it tastes so
But I love
good.
it. And so it's that balance. And that's what I'm talking about is trying to figure out, okay, what are you willing to do? Where do you want to be? I know tons of people that have gotten to 10% body fat and hated their life. So
So to recap, a really great way to reduce my health insurance costs, I mean, money that's going to come straight out of my pocket, is accepting the fact that we're all unique individuals. There is no solid one answer. The eat right and exercise may not be the right answer for everybody.
well, everybody should do that, but it's how you do it.
Okay, it's how you do
I'll
it.
clarify it.
Okay, so actually a really great point is reframe how eat right and
Yeah.
exercise comes in as what does that mean for me at my age, my lifestyle, my
Yeah.
access, all these different things.
Think about all the crazy talk out there that for years, fat is the enemy. And we're beginning to realize, actually, no, that wasn't true. Yeah.
Okay, well that makes a lot of sense.
Yeah. So I think the best way as you're optimizing your health, the reality is this. Most of us don't spend any time thinking about it until it's gone. If you're spending a little bit of time thinking about it, a little bit of time trying, and you've got somebody that you can work with on that, because there's tons of noise. One day coconut oil is great, the next day it's the devil. The reality is neither of those things. So get away from the noise, start working into some solid foundation for you and your health. That's the best way to lower your healthcare costs long term. And so, what I recommend for most people is to have access to somebody like myself and to wrap that with kind of the O plan of when something bad happens, you've got this higher deductible plan that can kick in. And when you're looking, one thing we didn't talk about is when you're looking at what type of health insurance should I choose?
Great question.
Yeah. So deductibles are your total out of pocket. So you're going to pay this amount of money, let's say $4,000 out of your own pocket, and then after that, the insurance will pay it.
Okay.
Now, there's usually kind of a breakdown of up until that $4,000, you pay 80%, they pay 20, or whatever that is. But there's your deductible. And then there is your premium, which is what you pay monthly. But there's also this other thing we don't talk about, which is your total out-of-pocket cost. So a lot of times I'll have people bring me two different plans that they're looking at. And the deductible's low. So the deductible maybe is $2,000. And then the other one is $5,000. And the premium price is based solely on that difference. So let's say the $2,000 lower deductible is $180 a month. That's your premium. And then let's say the $5,000 deductible is $60 a month. Because you've got higher risk here. A lot of times that total out of pocket's almost the same. So for those two plans, the total out of pocket was $7,000. So sure, the first $2,000 you pay, and then you pay 50% of until you get to, no matter what, something bad happens, $7,000. Over here, you just pay more of it, a little bit, but still your total out is $7,000. So if you're making a decision about this for only if only bad things happen, you should be looking at your total out of pocket. What am I okay with? Bankruptcy. The number one cause of bankruptcy in America is healthcare costs.
I read that. I was curious
so number
if
one.
you knew that one.
So if you look and you say, okay, hey, I'm okay with $7,000, then why wouldn't you pay $120 less a month and either save that money or for $60 a month, get me, and save the other portion as your oh no. You know, if those things were close, if you're talking a $10 a month difference, okay, fine.
Right.
But if you're talking a $120 a month difference or what have, that's a big deal.
Well, that's something to consider. I mean, most people think of bankruptcy as, your business fails and goes under and all that type of stuff. But to your point, the statistic about it being the number one reason for bankruptcy is actually fascinating. It could be something that you broke your leg, you developed a cancer or whatnot, and now you're bankrupt.
Yeah.
And that's something we never think about. It's not your fault, unfortunately, but that's what happened.
Yeah, something bad happened. And I look at those and I go, okay, thankfully I've got some friends and family around. If I couldn't cover that $7,000 immediately, we could get there, or I could work with them.
Right.
But if you don't have that $7,000 cap or whatever it is, I don't encourage people to not have something. I use a health share account. So there's a variety of, most of them are faith-based ministries that have created health share accounts. It's basically like a credit union for your health insurance. They say they're not insurance, but they meet mandates, which will no longer matter next year. And they're a lot less expensive. So I would say probably 4 times less expensive for my family than it would be to go out and get a traditional model as a small business owner, independent entrepreneur.
So it's a great question, because if I'm listening to this podcast and I'm somewhere else in the United States, not here in Kansas City, are there direct primary care doctors? Is that in my area? Is that the right term? Like, how do I go find who the Damon Heybrock of Seattle is?
Yeah, thankfully, we are one of the fastest growing kind of portions of health. And so they're not everywhere. But I mean, my small town, Norfolk, Nebraska, I think there's 2. And so they are
guys just like
increasing.
you.
Mm-hmm.
Guys or gals just like you.
Yeah, folks like me. And just like any doctor, they're going to offer different things or do a certain amount. One of the beauties of this is the flexibility of it. We're not all cut out of the same swath, and we do things a little different, but the general idea is the same.
One odd question before I get to my last question.
Yeah.
If I'm trying to reduce my health insurance costs, I'm trying to self-diagnose, and I'm Googling and I go on WebMD, is that a valid place to self-diagnose?
No. So one of my passions, my belief is by having that access, I keep you off of Google MD, Facebook MD, WebMD. Google MD ends up all places point to cancer.
Right. You're dying from something.
You're dying. The Facebook MD of taking pictures and posting them and saying, hey, does anybody know what this rash is? There's tons of really bad information on there.
Yep.
So no, it's a bad deal. I understand why people do it. It's the same thing.
I
but-
had an employee who was very much that way, who had a rash on her body, and she went the Google path,
Yeah.
and she came in crying because she thought she was dying.
Yeah.
She had just assumed she
Yeah.
had this terrible disease, and I'm like, hey, you might want to just call somebody, right? Like, that's a dangerous place because we're not
Yeah.
educated, right? There's
Yeah.
a reason why doctors go to school.
Yeah.
It's a reason why they have to go practice. It's a
Yeah.
reason why they're regulated a certain
Absolutely.
way, is to do these things that we're not using Google for.
Yeah. So please get off of Google MD.
So last question.
Yes.
If I'm still confused, actually second to last question. If
Yeah.
I'm still very confused about all this, where do I start? Do I call and look for a doctor I like? Do I go to the Google MD route? Where do I start?
Yeah. I mean, if we're talking specifically around health insurance and access to a doctor and coverage, that sort of a thing, then I would say find a DPC doc. We're generally equipped to have good relationships with
Direct primary care.
direct primary care, which if you just Google direct primary care in your area, you'll find us.
Okay.
I think there's a dpc.org that kind of has a list, maybe a map of all the areas. Don't hold me to that.
Okay.
But like I have a couple of independent insurance brokers that are really creative. And so I'll connect people with them as individuals. You can self-insure. A whole conversation around this idea of self-insuring could be another podcast. And you can do that if you have 2 employees. And that can save you a ton of money. And so I've got people that I can refer to for that, and most of us do. And so that's a great place to start. If you're just shooting in the dark, it's a pretty hard spot to be.
Now it's the last question.
Yes.
What is the one takeaway you want all the potential listeners to really understand, whether they understood or they're confused by this or whatever? What do you want them to walk away and just know and understand and embrace?
You are responsible for your health. But there are people that want to partner with you to engage that health. I think we've handed the keys over for far too long. Insurance, it's smart. You make a really expensive and painful decision once a year. It's taken out of your paycheck. You don't ever see it. And you hope you don't ever have to use it. And so we've accepted that as a status quo. Don't do that. Engage it. You're responsible for it. There's better ways, and there's people who want to partner with you in that.
I think that is good advice across the board, and also something that we've seen as a common theme here on the show of education, of, a lot of the stuff in this world is incredibly complex.
Yeah.
And educating ourselves beyond school,
Yeah.
right? Like the continual education that we have is going to be ultra important for us to survive and get by and not keep raising the rate of bankruptcy in America and, not increasing our death rate in America. And so I think that to your point, that you put it in great, you basically the world gave us the keys and said, hey, learn how to drive.
Yeah.
Right. And that's a dangerous thing.
Yes.
Very dangerous thing. Well, I appreciate you coming on the show.
Thanks for having me.
I appreciate you educating everybody out there. If people want to find out more about you,
Yes.
or I heard that you have your own podcast coming out, why don't you tell the world how to access that?
Gotcha. So the best way to find me is healthstudiokc.com. It's the website. It's got all of my general information, contact information, all of that. We're on the gram at Health Studio KC as well. And then the Health Studio is a podcast that'll be coming out, and there'll be info on social media and on the website with all of that as it rolls. I think we're going to be rolling out in about 2 months. We're making them now. We've got 4 episodes done, hoping to finish 10.
Well, that's exciting. I'm looking forward to it. Have a wonderful weekend, and I really appreciate you coming on.
It was great being here. Thanks. I appreciate it.
Can you just explain it like I'm 5?